Welcome to Medical Grand Rounds. Thank you all for coming today. Today we have the pleasure of introducing Dr. Kasthuri, who is a relatively new faculty member here, recruited to the Division of Hematology and Oncology, and where he has gotten off to a fast start. I know many of you have seen him on consults. He's been very involved with coagulation service clinically. He's been very successful as an investigator. Recently got a R01 that's funded through 2013 and other grants, and has been productive. So he's another one of our young faculty who is doing a terrific job of balancing both a clinical career and a research career, and lots of teaching thrown in. Today the topic that he's going to talk about is one that I think is important for many of our patients and is an excellent general grand rounds topic, and that's on aspirin resistance. So Raj, thank you very much.
Thank you. Honored to give grand rounds. Start off with why aspirin resistance, considering I'm a hematologist to begin with, and we usually take care of the venous side of the plumbing and not the arterial. And the only time I see these patients in clinic is when it's that subgroup of patients who have had recurrent events, and the suspicion is if there is a coexisting hypercoagulable state that we can evaluate for. But if you review the literature on aspirin resistance, it's taken off exponentially in the last 5 years or so. There's a lot that's written about it. There's a lot in the media about it as well. But if you read the papers and actually look at what evidence this is based on, you realize that there's actually a lot more uncertainty with aspirin resistance, and rather than, sorry, hear me better? No? Now? Better now? Okay. So the question is really, how much of what we really see is aspirin resistance versus a failure in the effectiveness of aspirin that is not directly related to thromboxane inhibition. And before I start, a question to the audience. How many of you are familiar with aspirin resistance? And how many of you have actually thought about aspirin resistance in patient management or looked for it? And how many of you who said yes are cardiologists? Okay. All right. So my objectives, my three objectives for today are to very quickly review the evidence on aspirin prophylaxis, more for the benefit of the trainees and the students in the audience, both primary and secondary prophylaxis, and to make the case for aspirin resistance, but not the way it has been represented in the literature, because I think we tend to overcall it. And then address what potential treatment approaches we can, or there exist, to try and treat aspirin resistance or manage it. So overview, I'll quickly run through some of the data on arterial thrombosis prophylaxis, and I'll address the physiology of platelet activation. I know this is a black box for most people, and the minute I start talking about platelet biology, the residents start getting squirmy. So that I'll briefly address platelet activation and the effect of aspirin on, or the mechanism of inhibition. And finally close with aspirin resistance under the subheadings of prevalence, what are the potential mechanisms behind aspirin resistance, how can we go about identifying aspirin resistance, and finally, what can we do about it? Going back to what is taught in med school all the time, if you can't do something about a situation, why send off a test if you don't know what to do with the results? We do that all the time too. So a little bit of history, and I call this slide the Dark Ages. Aspirin is certainly a drug that's been around for centuries, and I read somewhere that about 40 metric tons of aspirin are consumed every year. It's certainly the most frequently used drug in the world. It's been around since the time of Hippocrates, where they used to make willow leaves and bark, make a decoction of it, and use it to treat joint pain. It wasn't until 1838 when the active ingredient in willow bark was identified as salicylic acid. But salicylic acid, as a lot of you may know, is not well tolerated, a lot of GI distress with it. And in 1897, they made acetyl salicylic acid, which is better tolerated. And this was by Felix Hoffman when he was working for Bayer, ergo the Bayer aspirin. But it wasn't until 1971 that we learned the mechanism of action of aspirin, and that was by Sir John Wayne when he published in Nature about the effect of aspirin on prostaglandins. Simultaneously, there was also a paper in Nature by Smith and Willis on the effect of aspirin on platelets. And Sir Wayne actually got knighted and won the Nobel Prize in 1982 for his work on aspirin and prostaglandins. In 1976, COX was identified, cyclooxygenase, and soon thereafter identified as the target for aspirin. And over the last 20 to 30 years now, we have used aspirin for everything under the sun, thrown the kitchen sink at it, and still working on it. So what's the evidence for the use of aspirin in arterial thromboprophylaxis? So let's look at the data on primary prophylaxis first. There are 6 trials, large-scale trials, cumulatively over 90,000 people studied in primary prophylaxis with aspirin. The doses ranging from 75 to 500 milligrams. But as a number of you may know, the first 3 trials here on this list are only in men, and this is only in women. And again, a lot of patients, one of the 6 trials was actually closed ahead of time for ethical reasons and did not show any benefit. But what's the summary of all of that? What's the data? And here it is. It's basically, if you look at all-cause mortality and stroke and cardiovascular mortality, there is no significant benefit to using aspirin, right? The benefit is seen in the subset of patients only in prevention of non-fatal MI and total coronary heart disease. That's about 25% risk reduction. And if you look at total cardiovascular events, that is defined as composite of cardiovascular death, MI, and stroke, there's a less significant risk reduction, significant nonetheless, it's about 15%. But one of the observations that have been made in all of these trials is it studied a population that was not at risk. These are healthy people out in the community for primary prophylaxis, low risk to begin with. So what about secondary prophylaxis? That's much better established, I think. And you can split this into short-term therapy and long-term therapy. And the beacon for short-term therapy is the ISIS-2 trial, which is now 20 years old, and where they looked at streptokinase with or without aspirin, aspirin alone, placebo. So there's 4 arms, both together, either separately, and neither, and just placebo. And here's the data on the aspirin alone arm, where there is a 23% risk reduction or reduction in mortality at 5 weeks. So I think this is fairly standard of care now in the acute setting. What about long-term? Now, there have been hundreds of trials looking at long-term therapy with aspirin, and these were summarized nicely in this meta-analysis from the Anti-Thrombotic Trialist Collaboration, which is an update to their previous publication. This came out about 5-6 years ago now. And the take-home point there is a 25%. If you left stroke out and just looked at cardiovascular disease, there is a 25% risk reduction using aspirin in the secondary prophylaxis setting. One recurring theme in a number of these trials has been the benefit in stroke is not as marked as it is with heart disease. All right, so we'll move on to, it's 2 days from the election. I have to do something about that. I'll stay nonpartisan though. So physiology of platelet activation. So here's a cartoon of a platelet with everything in it, the alpha granules, dense granules, mitochondria, and there's alpha granule and delta granule release. So in 3 slides, I'll run through the 3 stages of platelet activation. Here's a cartoon of red blood cells, laminar flow, red blood cells in the middle, platelets out in the periphery, endothelium, subendothelial collagen. Now, when there is injury and exposure of the subendothelium, and the collagen comes in contact with the platelets. Now, you have, as all of you know, 2 receptors on platelets that can interact either directly or indirectly with collagen. Glycoprotein 6, which directly binds collagen, and the 1B95 complex through binding with 1 Willebrand factor, which then hooks onto to collagen. So the goal or the events in initiation are rolling, leading to arrest and activation of platelets. Now, the end result of all of this is going to be a monolayer of platelets adhering to the endothelium or the subendothelium at the site of injury. Once collagen has bound to its receptor, then there's a whole bunch of intracellular signaling events that I will not go into. But I've tried to summarize that here. The goal of that, the second phase, is basically extension of the platelet plug, if you will. And the events basically are threefold. Once you bind to collagen, once a platelet binds to collagen, you release the granules, the contents of the alpha and the delta granules in the platelets, delta alpha. And delta granules basically have ADP, serotonin, while alpha granule has other fibrinogen and other procoagulants. In addition to granule release, there is also what is called inside-out signaling, which is basically, let me back up and say there is 2B3A receptors on the platelet normally, but they don't bind fibrinogen, otherwise none of us would be sitting here, right? But then once you activate the platelet, there's inside-out signaling, there's a conformational change to 2B3A, which then enables binding to fibrinogen, and that's the second event that happens. And the third is you start the process of thromboxane synthesis and release through arachidonic acid, which is mediated by COX, and we'll get to that. So once this happens, the net result of that and the ADP release and the thromboxane release is activation of surrounding platelets as well as feedback activation of the same platelet because of the receptors on the surface, the net result of which is going to be formation of a platelet plug. And so this is the third phase, is aggregation, where you have outside-in signaling from all the released contents, irreversible aggregation, and clot retraction. So a platelet that looked like that now looks like that. So what's the mechanism of platelet inhibition by aspirin? Here's my cartoon of a platelet with the phospholipid membrane. And once you activate the platelet, you've got the calcium efflux that happens intracellularly, activation of phospholipase A2 that leads then to prostaglandin H2 and ultimately thromboxane A2 synthesis. And there's cyclooxygenase. Now this thromboxane A2 is going to go out and signal back in through the thromboxane receptor or signal on neighboring platelets, activating neighboring platelets, propagate the platelet plug. And aspirin primarily works, as you all know, by inhibition of COX-1. This is on our economy, as it is today. So moving on to aspirin resistance. And what I'd like to cover is basically first of all, we need an acceptable definition of what aspirin resistance is. And if aspirin resistance is actually a misnomer, should we call it aspirin failure or aspirin non-responsiveness? It's also being called inadequate aspirin efficacy, all going to the same thing. So I think the first report that I could find of something hinting at aspirin resistance was this paper in the JCI over 25 years ago now, where they basically described that although the platelet aggregation response to ADP ex vivo was inhibited during administration of lower doses of aspirin, and they started off at 25, 30 milligrams of aspirin and went all the way up to 2.6 grams, the aggregation response returned to control values despite ongoing therapy for inhibition of thromboxane biosynthesis. And this was in healthy controls, not patients. So where is the field now? And this is just Medline articles on aspirin resistance. So if you look at Medline articles, 2 articles or 4 articles between 1993 and 98, nothing before then. 99 to 03, there's about 40 articles. In the last 5 years, you've got over 200 articles that have been published. And what's really interesting is you've got 226 original articles, but there's already close to 100 reviews on these articles. But then nobody goes to PubMed first these days, so let's look at Google, right? Almost 300,000 hits if you put aspirin resistance in Google. So it's everybody is at least talking about it. We've got people in the industry making new devices to measure aspirin efficacy in everybody. This is being widely publicized. So it's only going to be a matter of time before your patients come and start talking to you about aspirin resistance. So how do we define aspirin resistance? One common definition is this: the occurrence of arterial thrombosis despite aspirin therapy. But that inherently means that everybody you give aspirin to should work, right? Which is not the case, as we all know. So the point is, aspirin failure does not equal aspirin resistance. So I think this would be a better definition of aspirin resistance: the inability of aspirin to produce a measurable response on ex vivo tests of platelet function, to inhibit thromboxane synthesis in vivo, and ergo to protect individual patients from recurrent events. So some considerations that we should keep in mind anytime you worry about aspirin resistance or failure. We have to remember, as you all know, that arterial thrombosis is a multifactorial disorder, and an individual's risk changes over time. So you have to be careful not to assume that the patient you saw in clinic 2 years ago, who you put on aspirin, who now returns with a recurrent event, that all else has been status quo, and the only thing is this is aspirin failure, because other risk factors also evolve. He might have put on 50 pounds in the last 2 years. Uncontrolled hypertension, diabetes, there's so many other risk factors that you have to think about. And none of these have been addressed in any statistically appropriate way in the trials or the data we have on aspirin resistance. There's so many variables that have not been accounted for. And to begin with, in developing an assay for aspirin resistance, you have to be aware that there is a lot of inter-individual variability to the aspirin response. This has been shown in the 80s in healthy individuals. So if you're going to look at what are potential causes for aspirin failure, you can divide them into COX-1 related causes, things that directly affect COX-1 inhibition, and COX-1 unrelated causes. And I think the first one, and much of these COX-1 related causes go to the bioavailability of the drug in the system, primarily compliance, first of all. There have been a few papers now on compliance as one of the key causes of aspirin failure, and I'll show you some data on this. And then we have to keep drug-drug interactions in mind. There are other drugs that can interfere with aspirin in COX-1 inhibition and binding to COX-1. NSAIDs, not all NSAIDs, but we do know ibuprofen, naproxen do competitively bind COX-1. So if you take ibuprofen and aspirin at the same time, you are going to have less inhibition potentially because the other NSAIDs are not irreversible inhibitors, but they will compete. And then there's the issue of decreased absorption. There's data showing enteric-coated forms of aspirin may not have the same bioavailability as straight aspirin. And also concurrent use of proton pump inhibitors can interfere with absorption. Accelerated platelet turnover is another thing to keep in mind. The doses of aspirin have been worked out, and we know that low-dose aspirin is good at inhibiting platelet COX-1, but that has been in primarily healthy individuals. We don't know what happens and if an increased dose is necessary, say in somebody who's got a pneumonia, who's got another inflammatory process, somebody who's got arthritis, any reason following acute coronary syndromes, any reason that increases platelet turnover. Normally we turn around about 10% of our platelets, we know that, but when you increase that turnaround, is the dose of aspirin still enough? In initial studies that were done in the 80s, they did look at doses as low as 20 milligrams, and the 75 milligram or the 81 milligram aspirin that we use here is thought to be many-fold greater than what is really needed to inhibit platelets at steady state. But that may not be the case in somebody whose system is stressed and who are turning out a greater number of platelets. What about the impact of age and weight? So we do know that in the general population, forget about aspirin resistance, there is variability. If you looked at the primary prophylaxis data that we discussed a little while ago, the women's health studies showed the benefit was more in older patients over 65 among the women. So does age matter with regards to aspirin failure as well? And there is some data on weight as well. And this issue of underdosing, if you're talking about weight, then should actually aspirin dose be weight adjusted? And finally, COX-1 polymorphisms as well have been reported. Now, what about COX-1 unrelated causes? There are reports on increased sensitivity to ADP and collagen in that subset of patients who show aspirin resistance, and I'll show you some data on that where they show there is increased sensitivity to ADP and ADP-mediated platelet activation in patients who develop aspirin resistance. And then keep in mind, endothelial cells and monocyte-derived PGH2 can bypass COX-1 and therefore cause platelet activation. Goes to the what you see repeatedly in the literature, which is there are other mechanisms of platelet activation independent of COX-1 and thromboxane generation as well. Now, receptor polymorphisms in glycoprotein 3A and certainly the other agonist receptors on the platelet, the P2Y12 system, for example, have also been documented, which basically the net result of which is a hypersensitivity of the platelet despite use of aspirin. Stress can induce COX-2 expression. As you all know, COX-2 is not constitutively expressed, while COX-1 is, but stress induces expression of COX-2. Now, stress may induce expression of COX-2 in platelets, and we know that aspirin is not as effective in COX-2 inhibition as it is in COX-1. And finally, you can have upregulation of COX-2 and increased isoprostanes leading to thromboxane synthesis as well. What are some of the conditions that are associated with that? Smoking, diabetes, hypercholesterolemia, there is data on. So let's talk a little bit about compliance and aspirin failure. Now this is a paper that was published about 3 years ago where they looked at 191 patients, all of whom had a prior history of myocardial infarction and were currently treated on 325 milligrams of aspirin for secondary prophylaxis. And they looked at aspirin resistance in these patients using an arachidonic acid-induced platelet aggregation, which is what is fairly standard. And I'll address the definition of aspirin resistance using this assay in a little bit when I talk about assays. And the design was this. They brought in all the patients. At study entry, they measured aspirin resistance based on aggregometry, took all of the patients off of aspirin for a week, and then they brought them to clinic and gave them a supervised dose of 325 milligrams of aspirin, and then 2 hours later, repeated aggregation. And what they found was, at study entry, 9% of the patients had labs consistent with aspirin resistance. But then when they supervised aspirin therapy and then repeated it, it was only 1% or less than 1%, one patient. So they make the case for compliance being one of the key reasons for aspirin resistance. Now, what about data on enteric-coated aspirin? A lot of the aspirin that patients take are enteric-coated. Now, this is a study that looked at does entry-coating aspirin affect bioavailability. This is a study in 131 patients, all of whom had known coronary vascular disease and were on 75 milligrams entry-coated aspirin. And they measured platelet aggregation and thromboxane B2 levels in these patients. Now, thromboxane B2 is the direct metabolite of thromboxane A2, and has been used as a surrogate for thromboxane A2 synthesis. So when they compared both of these and looked initially, out of the 131 patients, they found that 44% had detectable thromboxane B2 levels in their system, meaning there was ongoing thromboxane A2 synthesis in these patients. And when they did platelet aggregation studies on the same, they found that 21% of the patients actually had platelet aggregation studies consistent with aspirin resistance. So that is 21% of these 44% of patients. I hope that's clear. So not everybody who has detectable thromboxane B2 levels, which is here on this graph, actually has aggregation studies positive for resistance. That's that subset. Compared to only 3% of those who did not have detectable thromboxane B2 levels in their system who had positive platelet aggregation studies for resistance. So, and that's what's shown here, basically thromboxane levels on the x-axis, platelet aggregation on the y-axis, and here are the patients who have elevated thromboxane levels and positive platelet aggregation studies for resistance. But there is quite a spread of population here who have detectable thromboxane B2 levels, but then the aggregometry is not sensitive enough to pick up resistance. This may be a threshold issue here, and the sensitivity of the assay as well. And when they tried to find out what were independent predictors of aspirin resistance, they found that age and weight were independent predictors. Younger age, higher weight. But then if you look at recurrent events, or if you look at the subset of patients at high risk and who get recurrent cardiac events, that's pretty much the same population, is it not? Early events, overweight. And finally, what about ADP sensitivity in aspirin resistance? This paper basically looked at 72 patients who had stable coronary artery disease and used a test called the PFA 100, and I'll get to assays in a second. So I'll tell you a little more about what the PFA 100 is, but it's basically a way to detect platelet function. And they did PFA 100 and ADP-mediated activation, platelet activation assays using flow cytometry. I won't go into details of that, but the take-home message here is using the PFA 100 system, they found that 29% of patients had resistance to aspirin. Now, what they also found was in that subset of patients, now here's the aspirin-sensitive group and the aspirin-resistance group. In those patients who were aspirin-resistant, the closure times on the PFA 100 with ADP, which basically reflect ADP sensitivity, if you will, were shorter, meaning they formed a clot sooner than those that were aspirin-sensitive. And this is where the data for could patients who are aspirin-resistant actually be more sensitive to have higher sensitivity to ADP comes from. Now, the mechanism of this is not well established. I mean, is this because there is increased receptor expression on the platelet surface for ADP? It's certainly possible. All right. Global warming. So how do we assay aspirin resistance? So there's a whole bunch of tests, and I just listed the ones that have some data to support their use. First of all, how do we assess aspirin resistance by optical aggregometry? This is thought to be the gold standard, if there is a gold standard for this. And this is defined as a greater than 20% aggregation with arachidonic acid and a greater than 70% aggregation with ADP while the person is taking aspirin. So here's what normal platelet aggregations look like. This is a little backwards because 0 is up here, 100% is down the bottom. And this is a normal control patient, not on aspirin. And number 3 here, the blue line is platelet aggregation with arachidonic acid. And in somebody who's on aspirin, this should be a straight blue line up here. You should not aggregate with arachidonic acid if you're therapeutically on aspirin. So the problem with this test is it's very labor intensive, it's operator dependent, and between institutions there's issues with reproducibility, although it does tend to correlate well with clinical outcomes.
How much does it cost? Is it a big cost?
Platelet aggregations, probably I think $1,500 to $2,000 at UNC. But then the blood has to be processed in a very specific way. So we have to tell the coag lab ahead of time. So you have to make an appointment come. It's certainly not possible to do this in everybody you're worried about aspirin resistance for. If the prevalence of aspirin resistance is anywhere close to what it is made to be in the literature. Now, what about aspirin resistance using a PFA 100 instrument? Now, here's a cartoon of how this instrument works. It's basically you take whole blood, pass it through a capillary at shear rates that mimic arterial flow, and then it comes against an aperture which is lined with collagen and either ADP or epinephrine. And the concept is basically once platelets come in contact with collagen and epinephrine or collagen ADP, they get activated, and you basically time how long it takes for complete stoppage of flow, and so formation of a platelet plug. And using this instrument, aspirin resistance is defined as a closure time for collagen and epinephrine of less than 164 seconds despite aspirin intake. Now the normal ranges here for aspirin, for collagen and ADP are about 110 seconds. And in somebody who is on aspirin, it should be indefinite. It should be really long. So despite use of aspirin, if you have less than 164 seconds on your closure time, then that's consistent with at least inadequate inhibition of thromboxane synthesis. The advantages of this are it's simple, fast, and uses whole blood. Disadvantages are it's hematocrit dependent. So if you're anemic, if hemoglobin is less than 10 or 11, then that by itself can prolong your closure time, so you have to be careful. And also it's von Willebrand factor dependent. That's something to keep in mind. Now here's another assay called the Verify Now Aspirin assay. It's a turbidimetric optical detection system. It's a tabletop instrument. This is again aggregometry using whole blood instead of PRP. And the concept is basically you have a cartridge that's got beads which are coated with fibrinogen, and you have a platelet activator. You can use arachidonic acid, and you basically measure aggregation. Finally, there is this, you can measure metabolites of thromboxane A2. So there is, you can measure thromboxane B2 either in serum or in urine, and this Aspirin Works test is basically measuring thromboxane A2 in the urine, and that has been used in a couple of large-scale studies, and I'll show you the results of that in a bit. But the advantage to this test is you can use frozen samples because it's metabolites and you don't have to store platelets, which, as you all know, can't be done. Now, what about comparing all of these assays? Here's a study that looked at patients who were on aspirin following TIA or stroke, 100 patients, and they compared using optical aggregometry, PFA, and the Verify Now assay, and looked at prevalence of aspirin resistance based on these assays. They found that 5% of these patients had aspirin resistance by aggregometry, 17% by Verify Now assay, and 22% by PFA 100. Now, the more important thing is how many of these patients had all three consistent with aspirin resistance? 2 of them. And that is inherently the problem. It's a problem of concordance between assays. And here's another paper reviewing 34 articles in the literature on the prevalence of, and looked at prevalence of aspirin resistance. What's interesting about this study is it's probably one of the few studies that question aspirin dosage. They they basically found that the prevalence of aspirin resistance was greater in those patients who were treated with less than 100 milligrams of aspirin as opposed to greater than 300 milligrams of aspirin, 36 versus 19% prevalence of resistance. Again, if you looked at what instrument or what assay was used, if you used aggregometry, it was only 6% prevalence as opposed to using the point-of-care devices where it was higher. So what's the bottom line on these assays? Most of them lack sensitivity, specificity, and reproducibility, and there's very poor correlation between these assays. And what about the prevalence of aspirin resistance? So what's the data on that? There have been only 4 prospective large studies looking at the prevalence of aspirin resistance. And 2 of them used aggregometry, one of them the PFA 100 assay, and the other one used the Aspirin Works assay. So right there, knowing what we know about assays, I really don't know what that means because they're going to give you different numbers. We know that. Using aggregometry, at least consistently, you have a lower prevalence as opposed to the others. In this study, where 326 patients with coronary vascular disease were looked at, 5.2%. And they did find that there was the hazard ratio for death, MI, and CVA was higher, 3.1, in patients with resistance as opposed to those who were sensitive to aspirin. Again, the studies on using the other devices, the prevalence is much more, between about 20 and 25%. But they have been consistent as well. So are the tabletop or the point-of-care instruments measuring something that aggregometry is not measuring? That's a possibility. If you look at how you do aggregometry, you are selectively activating platelets. So the aggregometry may focus or does focus only on the platelet, but then if your source for COX is coming from, or if your activation of COX, if you're coming down the COX-2 pathway, or if you're activating or if your thromboxane is coming from monocytes from the endothelium, platelet aggregation studies will not pick that up. Now, is that the reason why the other point-of-care devices have higher prevalences? Maybe. That has not been looked at. So finally, what about management of aspirin failure? Like I said, if you do a test, you have to know what to do with the results of that test. One thing you could do is you could correct modifiable risk factors: patient compliance, drug interactions, smoking, effective management of comorbidities, diabetes, hypertension. Now, I think you can make a case for temporarily increasing the dose of aspirin during times of stress and increased platelet turnover. Short periods of increased dose of aspirin are not associated with significant adverse events, so I think it'll be a fairly safe thing to do. Is there data to support that? No. And you could consider dual platelet therapy. Certainly, going by the data on increased ADP sensitivity, it makes sense to use dual therapy and inhibit, and use Plavix against P2Y12 as well. Now, the kicker there is, if most of these patients are high-risk patients, shouldn't you be doing that anyway? And that's a question for the cardiologist. Now, my take-home points. I hope I've convinced you that there is an entity called aspirin resistance, although I don't think it's as prevalent as 20 to 30% of patients who are on aspirin for all the reasons we've discussed. As we all know, arterial thrombosis and therefore failure of aspirin prophylaxis is multifactorial and difficult to tease out what the contribution of aspirin is to this. The aspirin resistance is, like I said, likely real, but if you ask me what it would be, I'd estimate that it would be about 5 to 6%. I tend to believe in platelet aggregation studies, but again, I'm a hematologist. There is a lack of concordance between the different assays to measure resistance. And finally, for all of these reasons, the ACCP guidelines that came out a few months ago clearly state that they do not recommend testing for aspirin resistance as things are right now. They do agree that more studies need to be done, but I don't know how somebody is going to do a study which accounts for every variable that is a risk factor for cardiac disease or vascular disease, and design a study. It's going to take many, many, many thousand patients to do a study that way. So finally, I'll close with a reintroduction of the coagulation group at UNC. all of you all know most of these people, Dr. Roberts, Dr. Mall, and Ma. New addition, not new anymore, Dr. Key, who came down in 2005 from Minnesota. And there's me. I've been here a year. And one person that I should put up there who is also new, who some of you may not know, is right there, Dr. Nigel Mackman, came to us from Scripps about a year ago, by the same time I came down. He's the John Parker Professor of Medicine, and he is a scientist, runs a huge lab that's getting bigger every day. But if some of you are interested in working in coagulation, there's another resource for you all. I'll stop there and take questions. Thank you. Yes, sir.
A couple of questions. So, who would you get further testing for aspirin resistance?
I personally would not test for aspirin resistance, because if you're worried about aspirin resistance clinically, it is in somebody who's already had a recurrent event or is at a very high risk for a recurrent event, in which case wouldn't it be more of a case to say, let's actually use more than one antiplatelet agent, regardless of what the aspirin resistance testing is going to show you. So I don't think, as things stand now, that we should go after testing for aspirin resistance.
Could you comment on, you made a brief mention about the fact that probably the aspirin doses you use are larger than needed on one hand. On the other hand, you commented on potentially going up on the aspirin dose. So kind of tell us what you think about the range of aspirin dosing.
So the studies on dosing of aspirin were done in the 80s, where they tried anywhere from 20 milligrams to 2 grams of aspirin, and found with regards to the antiplatelet effect or platelet inhibition of aspirin, even 20 to 30 milligrams is adequate. And you take out greater than 95% of thromboxane synthesis with that dose. And that's where the recommendation for 75 and 81 milligrams is adequate comes from. But then the question is that dosing enough in people whose platelet turnover is higher, albeit transiently, like most patients in the hospital, for example? In those patients, should we be increasing the dose? I think it's a valid argument. It has to be prospectively looked at to see if it can be done. I'm not worried so much from the bleeding complication standpoint, because it's only going to be for a few days or a couple of weeks, and I think we could safely do that if you hike up the dose to 325 milligrams. But that has to be prospectively looked at. Now, I don't know what there's one study that I presented where they found increased aspirin resistance in the subset of patients who were on lower than 300 milligram dose of aspirin. This is known patients, known CAD patients. But then that was, again, it depends on which assay you use to look at it. With the PFA 100 assay, they found it was 26% prevalence. But even in that study, if you use platelet aggregometry, it was less than 10%. So which again goes to what is the ideal test to do this?
Raj, it seems like until you have really some working definition of what actually constitutes the phenomena, really you can't use any of the tests as the gold standard. Right?
Correct.
I mean, all of them are tests with linear outcomes where you set a arbitrary threshold. So,
right.
To me, even interpreting 6% versus 22%, you can change those just by changing the cut point to define aspirin.
I agree with you. I agree with you, because again, what is the normal ranges are developed from a bunch of normal people, and again, knowing how much platelet variability can be there in individual variability in the healthy individuals. What is the inter-individual variability in patients who have coronary artery disease in platelet function, and where do you even begin to make a normal cutoff? Is a valid argument.
Start with case control kind of data and look at people who have recurrent events versus those that don't, and do all the assays and see if you can find separation by group. I mean,
right.
Big numbers in order to try to tease out some of the other factors.
Right. And that's the point I was making, is if you're going to do a case control study, then there are so many variables that you have to keep in mind. The numbers are going to be huge. But that's probably the only way we're going to be able to get at this. Yes, Steph?
Question to Dr. Smith, please. In your society, what do people discuss about aspirin resistance and whether one should act upon it or even test for it?
This has been an excellent summary of the situation. The current recommendations for low-dose aspirin are driven largely by the ATP trialist data, which you saw, and that is reduction of events is similar from 75 milligrams up to around 1,500 milligrams. And the observation in Bravo and Cure, control groups, that the bleeding was twice as great at higher dose aspirin than low dose aspirin. Now the absolute values are something like from 1.8% up to 3.6 or 4%, so twice as great sounds bad, but 96% of the people on adult dose aspirin didn't have any problem with bleeding. But those observations were felt to be sufficiently strong enough to change the recommendations to low-dose aspirin. We have been concerned that there really is a lack of evidence between the various tests for aspirin resistance for platelet reactivity and outcomes. Until we can correlate a given test with outcomes, there's been a reluctance to include them in guidelines, with one exception. And that was the guideline for placement of stents in the left main or a very high-risk coronary artery. There is a recommendation, which is totally by the seat of the pants, level of evidence C, that if there's evidence for aspirin resistance in that case, one should double the kilogrel from 75 to 150. No data at all. Emotional response. So they're high-risk patients. You have to follow them carefully. But we haven't included testing in any of the current guidelines, with that one exception, because of a lack of correlation between the test and clinical outcome. But I think you summarized it beautifully. Better off looking at compliance, non-says, other things that can affect or interact with aspirin than to think you need to increase the dose of aspirin.
And I've certainly seen out in the community people are prescribing aspirin and a proton pump inhibitor together for protective effects. Now that may be detrimental. And there's some data to support that as well. So.
Thank you very much.
Thank you.